Immunology Insights, Basics and Beyond, Chapter 64, Immunotherapy in Transplantation. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our last chapter, we explored how immunotherapy can support or restrain the immune system in infectious diseases, sometimes giving it extra tools to clear pathogens, sometimes calming it down to prevent collateral damage. Today, we move into another high-stakes arena where the immune system plays a double role: transplantation. A transplanted organ or stem cell graft can be life-saving, but to the immune system, it still looks like foreign tissue. Immunotherapy in this context is about managing that conflict, preventing rejection or graft-versus-host disease without completely disarming the body's defense against infection and cancer. So let's talk science. What do we mean by immunotherapy in transplantation? In transplantation, immunotherapy almost always means immune modulation rather than boosting. We want to first prevent the host immune system from attacking a transplanted organ, like kidney, liver, heart, and lung. And second, in stem cell or bone marrow transplantation, prevent the donor immune cells from attacking the recipient's tissues, so graft-versus-host disease or GVHD, while still preserving graft-versus-leukemia effects. The tools range from classic broad immunosuppressants like calcineurin inhibitors and steroids to modern biologics like monoclonal antibodies or co-stimulation blockers, and emerging cell therapies like regulatory T cells or tolerogenic dendritic cells. The ultimate goal is immune tolerance, stable graft function with minimal ongoing immunosuppression and preserved host defense. Let's look at basic transplant immunology, or why grafts actually get attacked. Any transplant brings in alloantigens, primarily foreign HLA or MHC molecules and minor histocompatibility antigens. The recipient's immune system can recognize these in several ways. First, a direct allorecognition. Recipient T cells see intact donor HLA on donor antigen presenting cells or APCs in the graft. This is a powerful trigger of acute rejection, especially early after transplant. Second, indirect allorecognition. Donor proteins are processed by recipient APCs and presented on peptides on self-HLA. This pathway contributes to chronic rejection and long-term fibrosis. And third, antibody-mediated responses. Recipient B cells produce donor-specific antibodies, or DSAs, against HLA or other donor antigens, leading to complement activation, endothelial injury, and antibody-mediated rejection, or AMR. In solid organ transplantation, the main problem is host versus graft rejection. In allogeneic hematopoietic stem cell transplantation, or HSCT, the situation flips. Donor T cells reconstitute the immune system and can attack recipient tissues with GVHD, while also providing beneficial graft versus leukemia activity. Immunotherapy in transplantation is therefore all about calibrating T cell and B cell responses to alloantigens, sometimes on both sides of the graft. Let's now look at the conventional approach, broad immunosuppression. Most transplant regimens still rely on a combination of classic immunosuppressive drugs. First, calcineurin inhibitors like tacrolimus or cyclosporine. They block IL-2 transcription and T cell activation by inhibiting calcineurin in T cells. Second, antiproliferative agents like mycophenolate mofetil or azathioprine. They interfere with lymphocyte DNA synthesis and expansion. Third, corticosteroids like prednisone or methylprednisolone. They broadly suppress cytokine production, adhesion molecules, and multiple inflammatory pathways. And fourth, mTOR inhibitors like sirolimus or everolimus. They block mTOR signaling, inhibiting T cell proliferation and sometimes helping limit chronic allograft vasculopathy. A typical kidney transplant patient, for example, might receive high-dose steroids and an antibody for induction, followed by tacrolimus and mycophenolate and low-dose steroids for maintenance. These drugs have been remarkably successful at reducing early acute rejection and improve short-term survival, but they are non-specific. They suppress helpful immune responses as well as harmful ones, increasing risk of infection, especially viral and opportunistic ones, and malignancy, such as post-transplant lymphoproliferative disorders. This drives the search for more targeted immunotherapies and ultimately tolerance. So let's look at antibody-based and targeted biologics in transplantation. Over the last decades, biologic agents have become central to transplant immunosuppression, especially in induction therapy and rescue of difficult rejection episodes. Let's look at them one by one in more detail and start with induction therapy, so front-loaded immunomodulation. Right around the time of transplantation, many centers use biologics to strongly dampen T-cell responses, allowing lower doses of the other drugs later on. Common approaches include: first, anti-IL-2 receptor or CD25 antibodies, for example in basiliximab. They block IL-2 signaling in activated T cells, reducing early expansion without complete T cell depletion. Second, polyclonal anti-thymocyte globulin or ATG. It depletes T cells more broadly and it is used in higher risk patients, for example with high immunologic risk or delayed graft function. And third, in some regimens, anti-CD52 like alemtuzumab is used to deplete T and B cells. These induction agents reduce early acute rejection but must be balanced against infection risk. Next, we have targeted agents for rejection and maintenance. Biologics also help manage specific forms of rejection and, in some cases, serve as maintenance therapy. First, we have anti-CD20, like rituximab. It depletes B cells and is often used in antibody-mediated rejection or to manage high levels of donor-specific antibodies, sometimes combined with plasmapheresis and IVIG. Second, we have complement inhibitors like eculizumab with plasmapheresis and intravenous immunoglobulins or IVIG. Second, we have complement inhibitors like eculizumab or anti-C5, which is used in select high-risk settings such as ABO-incompatible kidney transplantation or severe antibody-mediated rejection to block complement-mediated endothelial damage. And third, we have co-stimulation blockage like belatacept or CTLA-4 Ig, which blocks CD28 CD80-86 interaction between T cells and APCs, inhibiting naive T cell activation. In kidney transplantation, for example, belatacept-based regimens can spare calcineurin inhibitors, potentially preserving kidney function and lowering some toxicities. These agents don't target the autoreactive clone or here the alloreactive clone directly, but they hit pathways that are disproportionately important for alloreactive responses. They are given at defined intervals and their effect can partially wear off, allowing some immune reconstitution over time. Now we come to cellular immunotherapies and tolerance strategies. Beyond drugs and antibodies, there is a growing interest in cell-based approaches that aim not just to suppress rejection but to actively promote tolerance. For example, with regulatory T cells or Tregs. Tregs are CD4-positive T cells specialized in maintaining immune tolerance. Strategies under investigation include: first, ex vivo expansion of recipient Tregs followed by infusion, hoping they preferentially dampen alloreactive T cells and reduce rejection or GvHD. Second, antigen-specific or CAR-engineered Tregs, designed to home to the graft and to suppress local alloimmunity more selectively. Early phase trials in kidney and liver transplantation, as well as in HSCT for GvHD prevention, suggest Treg therapy is feasible and can reduce the need for broad immunosuppression, though long-term data is still limited. Another example are tolerogenic dendritic cells and mesenchymal stromal cells or MSCs. The tolerogenic dendritic cells are conditioned ex vivo, for example with IL-10 or vitamin D, to present alloantigen in a way that induces Tregs or T cell energy rather than full activation. The mesenchymal stromal cells or MSCs are cells with immunomodulatory properties used in some protocols to reduce GVHD and promote graft acceptance, although mechanisms and optimal use remain under active study. Then we have the mixed chimerism and immune reset. One of the most robust routes in tolerance in experimental and some clinical settings is mixed chimerism, establishing stable coexistence of donor and recipient hematopoietic stem cells. In practice, this means first, transplanting donor bone marrow or stem cells, often alongside a kidney or a liver. Second, using conditioning regimens that allow donor hematopoiesis to engraft without fully ablating the host. And third, achieving a state where the immune system is partly donor-like and hence naturally tolerant of the donor organ. Some pioneering clinical protocols have shown that a subset of kidney transplant recipients can eventually discontinue all maintenance immunosuppression after establishing mixed chimerism. Now let's have a closer look at graft-versus-host disease, graft-versus-leukemia, and immunotherapy in hematopoietic stem cell transplantation or HSCT. In allogeneic HSCT, the logic flips. The graft is the immune system. First, we have the desired effect. So, graft versus leukemia or GVL, or graft versus tumor, where the donor T cells eliminate residual malignant cells. Second, we have the undesired effect. So the graft versus host disease or GVHD, where the donor T cells attack recipient skin, gut, liver, and other tissues. Immunotherapy here aims to separate GVL from GVHD as much as possible. Strategies include: first, T cell depletion or post-transplant cyclophosphamide to reduce highly alloreactive clones. Second, ATG as part of a conditioning to limit severe GVHD. Third, JAK inhibitors, for example ruxolitinib, as targeted therapy for steroid refractory acute or chronic GVHD. And fourth, emerging Treg and MSC approaches to dampen GVHD while preserving GVL. Interesting, checkpoint inhibitors like anti-PD-1 for example can sometimes be used after HSCT to boost anti-tumor immunity, but at the cost of a significantly increased risk of severe GVHD. This underlines how finely balanced transplant immunology really is. Now let's look at the clinical relevance. So, balancing rejection, infection, and tolerance. Modern immunotherapy has dramatically improved transplant outcomes. First, short-term graft survival is higher than ever for kidneys, livers, heart, and lungs. Second, HSCT can cure many leukemias and lymphomas that were once uniformly fatal. But the price is chronic immune modulation with trade-offs. First, we have increased susceptibility to infections like CMV, the BK virus, or fungal infections. Second, we have a higher risk of certain cancers. And third, drug toxicities affecting kidney function, metabolic health, and cardiovascular risks. Clinicians therefore constantly adjust regimens, tightening immunosuppression during high rejection risks, then cautiously tempering where possible. Biomarkers of immune activity, donor-specific antibodies, and immune monitoring are becoming more important to guide these decisions patient by patient. Now for future directions, or towards true immune tolerance. Looking ahead, several trends define the future of immunotherapy in transplantation. First, more selective targeting, like CAR-Tregs, antigen-specific Tregs, and tolerogenic DCs tailored to each donor-recipient pair. Second, safer co-stimulatory pathways, refining agents like belatacept and exploring new checkpoints that could promote tolerance rather than broad suppression. Third, in vivo immune programming, using gene therapy, vectors, or nanoparticles to induce tolerance mechanisms directly in lymphoid organs or within the graft itself. And fourth, better immune monitoring, transcriptomic and cellular signatures that identify when a patient is truly tolerant and can safely reduce or even stop immunosuppression. The long-term vision is that transplantation moves from permanent pharmacologic suppression towards engineered tolerance, where the immune system actively maintains graft acceptance while keeping its normal protective roles. To conclude, immunotherapy in transplantation shows the immune system in one of its most delicate roles, not as a simple on-off weapon, but as a system that must be gently steered between rejection and vulnerability. From calcineurin inhibitors and induction antibodies to co-stimulation blockade, Tregs infusion, and mixed chimerism strategies, we now have a broad toolbox to help grafts survive and patients thrive. We are not yet at the point of universal drug-free tolerance, but every advance in targeted biologics and cellular therapies brings us closer to that goal and deepens our understanding of how the immune system distinguishes self from non-self in the most literal sense. In our next chapter, we will stay with the theme of immune intervention, but step back into history again, meeting the pioneer Shinya Yamanaka and his work on induced pluripotent stem cells. Before closing, I have a small request. If you enjoyed this episode and want to hear more, please like and subscribe. It's a small step for you, but it helps me a lot. So thank you for listening and see you next time.